Welcome to the conference session titled Prognosis and Bone Marrow Failure Diseases. Thank you for joining us. My name is Alice Hauk, Senior Director of Health Professional Programs, and I will be moderating the presentation today. As we get started, we recognize the generosity of the corporate sponsors and the generous support of patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. Please feel free to submit questions at any time during the presentation from the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing your question, hit enter. We will do our best to get to all questions. When asking questions, I respectfully ask that you do two things to help us manage the incoming questions. First, submit your entire question all at the same time. And second, please do not share private health information in your question. Our speakers cannot answer any specific questions related to your health care. In the beginning of the session, we will open the audience poll feature in the right-hand engagement panel. Please click on the icon in the panel to navigate between each as you watch the session. The poll will remain open for the first 5 minutes of the session. Today's specialist is Dr. Sandrine Niyongere. Dr. Niyongere joined the University of Maryland School of Medicine and the Marlene and Stuart Greenbaum Comprehensive Cancer Center as an assistant professor in 2018. Her clinical focus is in acute leukemias, myelodysplastic syndromes, myeloproliferative neoplasms, and bone marrow failure syndromes. Her primary research interests are in finding new therapeutic targets by understanding oncogenic signaling pathways involved in AML and MDS, as well as studying the role of the tumor microenvironment in the development of chemoresistance in leukemia. She also serves as an attending physician on the inpatient leukemia service, training fellows, internal medicine residents, and medical students. With that said, welcome, Dr. Niyongere.
Hello, I am so honored, and it's such a great pleasure to be with you today as we spend time talking about how I answer this very tough and challenging question, how long do I have to live? Understanding prognosis for bone marrow failure diseases. So today, this is going to be our roadmap on our talk today. We will discuss how to make a prognosis, including all the information that physicians gather in order to make a prognosis. There are many different types of bone marrow failure diseases. Today, we're going to focus on paroxysmal nocturnal hemoglobinuria, PNH, aplastic anemia, and myelodysplastic syndrome, or MDS. And then we'll talk about strategies for being ready for your appointments. So I'm going to be honest with you. I dread this question. This question is a challenging question. I have a patient in front of me with their family. They're trying to process the information that they have been diagnosed with a cancer. And an important part of diagnosis of cancer is how long do I have to live? What is my prognosis? You know, every patient has different values and beliefs. It's extremely important to be respectful of those values and beliefs. I have patients who do not want to know their prognosis as their family members are waiting for me to give them an answer. And I have patients who want to know every bit of information that has led me to their prognosis that I'm making for them as their family members are rushing out the door because they do not want to hear it. And then I have patients at various levels in between. And it's an extremely challenging question to answer, but it's an extremely important question to answer. Prognosis not only lets us answer how long you're going to live, but it's a critical piece of information that allows us to make treatment decisions. However, this does not change this extremely, extremely critical point, which is that prognosis is an educated guess about the likely course of your disease from beginning to end. And so we're trying to answer how long you might live with your disease. And another important fact is as we gain knowledge about these diseases and cancers, prognosis is going to change. New treatments are coming out, and which can change the outcome of your disease. So overall, prognosis is difficult to make, and it's challenging for several reasons. One, each person's unique. We're all the blue duck. Each person disease is unique and different. Everyone, behaves and differently to medications, and your prognosis involves many different factors, including things that are not related to the actual disease, such as your general fitness, your strength, your age, and then how the disease progresses over time can be very unpredictable from patient to patient. And then for the more rare diseases like paroxysmal nocturnal hemoglobinuria, we have less information about these diseases, and so compared to other more common cancers. And so that makes it challenging for some of those rare diseases to give an accurate prognosis. This is one of the hardest questions to answer as a physician. And so, ultimately, oftentimes there's no true right answer to this question. The reason is because, ultimately we really can't give a accurate, timeline of prognosis. Again, it's an estimate. But we're going to talk about all the ways that we come together to come towards a prognosis. So a lot of different information is collected in order to make a good prognosis. Your lab results, your blood work, your symptoms that you're having helps us come towards a prognosis. Your bone marrow biopsy results and other tests that helps us confirm your diagnosis also helps us make a prognosis. The previous clinical research, the previous research that we have on past patients and how they did, as well as the new treatments that we have today can influence prognosis. And then all of that comes together. We as physicians create, risk assessment tools to help us make these decisions for prognosis. And these risk assessment tools not only helps us with prognosis, but they also help us make treatment decisions. So how do we diagnose these bone marrow failure diseases? It starts with the history and physical exam, your meeting, your clinic appointments with your physician, as we ask questions about your previous health events, your medical problems, the medications that you're on right now. And then we examine you from head to toe to really get an idea of what these diseases are having, how they're influencing your body, what effect they're having. And then your blood work plays an important role because they tell, they're the first indication that there may be something wrong. And then we use that blood work to let us see how you're responding to treatment. And then the bone marrow biopsy and aspirate plays such an important role because that's what gives us a lot of the critical information on your disease. So all these tests are helping us to define, what is the abnormal cell, what is the cancer cell that's causing your disease versus your normal cells. In Myelodysplastic syndrome and leukemias, we're looking at the myeloblasts, or the blasts for short. These are the cancer cells that are driving and that are playing an important role in myelodysplastic syndrome and acute leukemias. These cancer cells grow more quickly than normal cells. They divide and grow rapidly, and that's what makes them cancerous. These blasts or cancer cells will spill out into the bone marrow, into your blood, and they may be the first indication that there may be something going on. They can also go into other organs. And so these tests help us to try to define what is the abnormal cell that's resulting in your disease. The bone marrow biopsy, many patients know this procedure very well. It's essential to establish the diagnosis, determine the classification of your disease, as well as gives us information about prognosis. So there's many different tests. The bone marrow biopsy is the procedure where we get the bone marrow sampled so that we can run all these different tests so that we can determine what your diagnosis is and get the information to help us make a prognosis. We look at the bone marrow to see what do your cancer cells look like. We look at the cancer cells to see what changes happen to make that cell become cancerous. We do chromosome analysis. We sometimes on your reports you'll see karyotype or cytogenetics. On the reports, we do a special type of testing called fluorescence in situ hybridization, or FISH, again, to try to identify the abnormalities that led to your cancer. We do flow cytometry, looking at the surface of the cells so that we can identify healthy cells from cancer cells. And then we look at the abnormalities, that the DNA or molecular, the mutations, again, to see what has led to your cancer. So here's more information about the chromosome or cytogenetics. So here's in the beginning, in the picture, you can see a picture of a cell. The cell is the makeup that comes together to build our tissue and our organs. Inside a cell, there's a nucleus, or the brain, that has all the instructions that tells the cell what to do. The instructions are organized into chromosome, and so you can see a picture of the chromosomes. And that's the instructions that tell cells what to do. And chromosomes are full of DNA or genes. And these are, and sometimes a change in the DNA or a change in the gene can result in a cell becoming a cancer cell. Flow cytometry is another way for us to identify cancer cells, as well as identify the different blood cells in your blood. It can help us differentiate, different cancers like Myelodysplastic syndrome and paroxysmal nocturnal hemoglobinuria. We use flow cytometry to diagnose PNH, and it helps us confirm the diagnosis, and we can also use it to evaluate if you're responding to treatment. And then last is the molecular testing. Most patients who are diagnosed with bone marrow failure disorders, they're going to do molecular testing to identify mutations. Mutations are changes in the chromosome in the cancer cell that cause the cell to become cancerous. These mutation testing are so important now because they help us with prognosis, because we know certain mutations are associated with a more aggressive disease, but we can also use this for treatment because we now have certain drugs that target specific mutations in chromosome changes. So here's a summary of all the tests that we do on your bone marrow biopsies that we all dread and don't want to do, but we must in order to get the information we need. And all of these results and testing that we do not only help us diagnose patients, but they also help us with coming up with the prognosis. So now that we've talked about all the different tests that we use in order to make a diagnosis, but also to make a prognosis, let's start by talking about paroxysmal nocturnal hemoglobinuria. So paroxysmal nocturnal hemoglobinuria, or PNH, it's a rare and acquired condition, meaning that it is a condition that develops over time. It is due to a loss of these specific proteins that are on the surface of our blood cells. Some patients, they do not have these proteins at all, and in other patients, the proteins are reduced in number. And so this loss or reduction in the protein on the surface of our blood cells can result in intermittent or chronic destruction of our blood cells, including our red blood cells within our blood vessels. So patients with PNH have different symptoms and different complications because of this loss of protein on the surface of our blood cells. So I have a picture of a patient who has been diagnosed with PNH. Because of the destruction of the red blood cells has this specific protein called hemoglobin. Hemoglobin is inside of the red blood cells. They hold on to oxygen, and that's what carries oxygen. When your red blood cells are being destroyed, the hemoglobin is released, and it builds up in our urine overnight as the patient is sleeping. And so patients with PNH, when they have when they use the bathroom first thing in the morning, they will see that their urine is dark or coke colored. So you can see at 7 a.m. it's very dark. And then throughout their day, the urine actually becomes less in color and becomes a more normal color as the hemoglobin is lost. And so this was one of the early tests to diagnose PNH, was checking a patient's urine throughout the day. And if their urine was dark in the morning and by the end of the day it was better, it gave us an idea that, hey, that this patient may have PNH. Now we have more sophisticated testing to diagnose PNH. So PNH, like we said, it's acquired. It's due to a loss or decreased amount of protein called glycosylphosphatidylinositol, right? A mouthful. It's called GPI anchored proteins for short on the surface of blood cells. Previously we would do these urine tests, but now we have these sophisticated testing, including flow cytometry, because we can use flow cytometry to identify if a patient has blood cells that have a loss or decreased amount of these proteins on the surface of the blood cells. Another test that your physician might do is called fluorescent labeled proaerolysine or FLAIR, which is used to diagnose PNH. So here's a picture of a FLAIR where this fluorescence labeled, meaning this compound is tagged, it's bound towards light. And so this proaerolysine is going to bind to patients that have the normal GPI anchored proteins. So here's a normal red blood cell with the GPI anchored proteins that is lighting up because it actually has these proteins. And then in red blood cells that do not have this GPI proteins, you can see that it's at the bottom, so you don't have the fluorescence. And so that's how we're able to diagnose a patient that has these abnormal PNH cells. Loss of these proteins can results in your immune system, your blood cells being very susceptible to being destroyed by your immune system. And so patients with PNH will have chronic destruction of their red blood cells with this, remember, the dark colored urine, because the hemoglobin is released from these destroyed red blood cells and it goes into your urine and it causes dark urine. Patients will also can have low blood counts because their blood cells are being easily destroyed. And so they may present with a low white blood cell count, a low red blood cell count or anemia, and then a low platelet count. PNH primarily affects adults. There's no clear preference for geography. So patients, we don't see this in one specific area versus another, or we don't see it more commonly in a specific ethnicity or a gender. Most patients are, diagnosed around their 30s, but we do see some cases in children. It's rare, but there are reports. PNH is really rare. We have about 1 to 10 cases per million, but we may be underestimating because it's so rare. It's not as sometimes as easy to diagnose, and so we may be missing patients. So it may be underestimated. So on to your left, so here's a picture of flow cytometry, where we're using flow cytometry, looking at the surface of our cells to identify patients with PNH cells. PNH symptoms, patients will present with many different symptoms. Sometimes these symptoms are due to the low hemoglobin or anemia because your red blood cells are being destroyed. So patients may have shortness of breath, fatigue, pain. PNH is known to have increased risk of thrombosis or blood clots, which can be life-threatening. Patients may present with jaundice or yellow skin and eyes. They may have red, pink, or dark urine, headaches, and then the big thing is the blood clots. Blood clots, can be life-threatening and dangerous, especially if you're having blood clots in your brain or strokes, which can be life-threatening. Blood clots in the heart and lungs, which can be life-threatening. PNH can also be associated with other bone marrow failure disorders. So we have patients who have PNH, and then they also have a diagnosis of aplastic anemia or myelodysplastic syndrome. So now you have all the complications of PNH, and then on top of that, you have the complications of having another bone marrow failure disease like aplastic anemia or myelodysplastic syndrome. So PNH can be very challenging to diagnose because you have a group of patients who have these abnormal PNH cells, but they don't have any symptoms. And so we may not be able to recognize that these patients have PNH. And then we have patients who have classical PNH where they have a large amount of those abnormal PNH cells, and they're having destruction of their red blood cells. They're developing blood clots, which can be life-threatening, and all the symptoms and complications because of it. Then we have patients who have PNH associated with other bone marrow failure diseases, such as aplastic anemia or myelodysplastic syndrome. And so it can be a challenging to diagnose patients with PNH. Now that we've kind of introduced PNH, let's talk about prognosis. So PNH is a chronic disease with significant symptoms and complications which can be life-threatening, including development of blood clots, as well as the presence of bone marrow cancers, such as aplastic anemia and myelodysplastic syndrome. Now, before, when we didn't have effective treatments for PNH, PNH, a lot of patients had a lot of symptoms and passed away because of the complications from having these blood cells being susceptible to being targeted by your immune system, resulting in them having low blood counts and the complications from PNH. Now we have these new effective treatments called complement inhibitors. And with these new effective treatments, we're starting to see that maybe we have improved patients' prognosis, and that prognosis may possibly be similar to patients who do not have PNH. So let's show you the data. Let's show you the research data. So before we had these effective treatments for PNH, which are these complement inhibitors, for patients who are aware of PNH or who have family members with PNH, some of the effective treatments may be we're watching patients very closely if they have no symptoms of PNH or their level of PNH cells are very low. However, in patients who have very high levels of PNH, or they have abnormal blood counts, or they're having the blood clots, which can be life-threatening, some of the effective complement inhibitors are ravulizumab, which was just approved in December 2018, or eculizumab. Eculizumab was approved in March of 2007, I believe. And so before these complement inhibitors were approved, which was the earliest is eculizumab, which was March 16, 2007, one research paper published that before these effective treatments in 2004, the outcomes of patients in the United States as well as in Japan, this paper found that the survival, meaning the number of years that patients lived with PNH in Japan was about 32 years, compared with 19 years for patients living in the United States. Some of the factors seen in patients with the worst outcomes, meaning patients who lived the shortest after being diagnosed with PNH, was age over 50. Likely this is because, as we get older, we develop more medical problems, heart disease, heart attacks, kidney disease, lung disease, COPD. And so as we get older, maybe we may have more medical problems, and then we add PNH to it, which causes stress to our body. Patients who had very low blood counts at diagnosis also tended to live shorter. Patients who had severe infection, we are now in the COVID-19 pandemic, and we've seen the effects of these serious infections can have. So patients with PNH who have had severe infection may live shorter lives. Patients who have thrombosis or blood clots, we know that blood clots can be very dangerous and life-threatening. And then patients with kidney failure. So before 2004, we saw that definitely patients with PNH lived shorter lives. And then depending on if you fell into these factors, it may cause you to have a shorter lifespan and a worse prognosis than a patient maybe who was younger, who had never had a blood clot, who had normal kidneys. Now, another study published in 1996 looked at 220 patients with PNH, and they found that the median overall survival, or the number of years that patients lived since the diagnosis of PNH, was 14.6 years. This study saw that 78% of patients were alive 5 years after diagnosis, 65% of patients were alive at 10 years after diagnosis, and then 48% of patients were alive at 15 years after diagnosis. And again, just like the previous paper research study, patients with the worst outcomes, meaning the patients who lived the shorter lives, tended to have had blood clots, again, because they're life-threatening. They had very low blood counts, low hemoglobin or anemia, low white blood cell count, which increases your risk of infection, low platelets, which again increases your risk of complications such as bleeding. These patients had PNH with myelodysplastic syndrome or developed acute leukemias, and then these patients tended to live long, were diagnosed when they were older, specifically diagnosed at age 55 years or older. So before these effective treatments, patients with PNH did live a shorter life, and then patients with specific factors such as history of blood clots, infections, low blood counts tended to live even shorter lives. Now with PNH, we have availability of these very effective treatments, which are the complement inhibitors such as eculizumab and ravulizumab. Remember that eculizumab was approved by the FDA in March 2007, and ravulizumab was approved recently in December 2018. And with these complement inhibitors, we have found that patients are starting to live longer. Now, patients, before these complement inhibitors, we found that blood clots, patients with blood clots tend to have worse outcomes. Here's a study looking at PNH patients who had blood clots in the brain. So this line right here, you can see that patients who had blood clots in the brain, we call this cerebral venous thrombosis, tended to live shorter lives, followed by patients who had blood clots anywhere, such as maybe the legs or other organs. They tended to live a little bit longer. And then patients who have never had blood clots tended to live a little bit longer. So the blood clots plays an important role in trying to allow patients to live longer with their diagnosis. And so here's a study of 79 patients who were treated with eculizumab, which was approved by the FDA in March of 2007. So these patients were followed over 8-year period. And what they observed is that with these new effective treatments, there's been a significant improvement in the overall survival, meaning that patients are living much, much longer with PNH on these therapies such as eculizumab. So here, the top line, you can see that patients with eculizumab, almost over 90% of patients are still alive, 8 years after their diagnosis of PNH by being on eculizumab, versus during the time when we didn't have eculizumab. You can see that there's a huge difference in the number of patients who are living with PNH. So with these effective treatments, since the availability of these complement inhibitors, the patients are able to survive PNH, and it seems as if they're living as long as patients who do not have PNH. Now, a very important caveat is these drugs are very new, right? Just, FDA approved in 2007. So we haven't studied these drugs long enough. We haven't had patients on these drugs for 30, 40 years. So we still need to do research. We still need to follow patients and evaluate how they're doing on these medications throughout their life. And so there's a lot of different registries, because remember, we talked about how rare PNH is. There's a lot of different registries that patients can sign on to. So if you have PNH, you can sign up for these different registries so that we can watch you and see how you do over time, and we can get a better idea of how long people are living with their PNH. So now that we've talked about prognosis and PNH, let us move to aplastic anemia. So what is aplastic anemia? So aplastic anemia is another rare and serious condition where your bone marrow fails to make enough blood cells. Remember, you have 3 cell lines: your red blood cells, which is what helps carry you oxygen and nutrients; your platelets is what helps you stop bleeding; and your white blood cell counts is what helps you fight infection. So aplastic anemia can be acquired, meaning that you developed it at some point in your life, or it can be hereditary, where you inherited it. It's passed down from parent to child. Most researchers believe that aplastic anemia is a condition that happens when your immune system attacks the bone marrow stem cells. Remember, your stem cells are the cells that give birth to the adult cells in your blood. So we suspect that this is an immune system problem. And that's the reason why, and we suspect this because when we suppress the immune system, patients will actually have improvement in their counts. So classification of aplastic anemia, we classify aplastic anemia by the severity of symptoms. So a patient who has severe aplastic anemia, the amount of cells in their bone marrow is less than 30%. So we know that the number of cells in your bone marrow is 100 minus your age. And so if you're someone, let's say, who is 30 years old, we suspect that we should see about 60 to 70% cells in your bone marrow. So if your bone marrow cellularity is less than 30%, we categorize that as severe, depending on how old you are. And then if the patient has a decrease in at least 2 of the 3 cell lines, remember the 3 cell lines are your red blood cells, your white blood cells, and your platelets. And specifically, if your neutrophil count, which is a specific type of white blood cell, is less than 500, your platelet count is less than 20, or if you are requiring blood transfusions, that along with the other criteria puts you in the severe aplastic anemia category. Patients who have moderate aplastic anemia, they have a decreased bone marrow cellularity based off of their age, and then they have a decrease of at least 2 of the following 3 cell lines, but they don't meet the criteria for the severe aplastic anemia, which is right above to remind you what that was. So that's moderate aplastic anemia. Now, patients who have very severe aplastic anemia, these are patients who fulfill the criteria for severe aplastic anemia, but their neutrophil count or that specific white blood cells that play such an important role in fighting infection, instead of being less than 500, in these patients, the neutrophil count is less than 200, so extremely low. So we classify aplastic anemia by severity, and that helps us guide us on prognosis as well as whether or not we need to start treatment. Because a patient who, has moderate aplastic anemia, they're not needing blood transfusions, they're otherwise doing well, we probably may just watch them closely and check their labs frequently, versus someone who has severe aplastic anemia. At that point, we would actually consider starting treatment. So what is the prognosis for aplastic anemia patients? So the standard therapy for aplastic anemia is immunosuppressive therapy. We suppress your immune system because we believe that aplastic anemia is a condition when your immune system is attacking your stem cells, destroying your stem cells, so you don't have the stem cells that you need to make the blood that you need. So ATG is an immunosuppressant, which lowers the body's immune response so that it stops your immune system from attacking the stem cells, allowing your stem cells to survive and make the blood cells that you need. ATG removes the specific cells attacking the bone marrow stem cells, allowing the bone marrow to grow and make the blood cells that you need. ATG is often used with another medication that suppresses your immune system called cyclosporin, which again suppresses your immune system. And then cyclosporin with ATG can sometimes be used with a medication called Promacta that helps stimulate your bone marrow growth. And with these, 2, sometimes 3 drugs, we're able to suppress your immune system and allow your bone marrow to make the cells that you need. So treatment for aplastic anemia oftentimes will include immunosuppressive therapy and then plus or minus a bone marrow transplant. A bone marrow transplant is when we take someone else's bone marrow that's healthy, that hasn't developed cancer, and that's a very close match to the patient that's developed aplastic anemia, and we actually give them those stem cells, and those stem cells go to the bone marrow, grow, and they replace the patient that, bone marrow that developed aplastic anemia. And so this is a graph showing prognosis in patients with aplastic anemia that received a bone marrow transplant, and their bone marrow donor is unrelated, meaning that these were patients who received a donor from Be the Match. Be the Match is a registry where people who are willing to donate their bone marrow, they register on Be the Match. And then when we have patients with the bone marrow failure disorders, and we decide that bone marrow transplant is their best chance of a cure, we type the patient, and then we find a donor in the registry that is as close as a match as possible, and we ask the patient on Be the Match, are you willing to donate? So this research study looked at 315 children, so that's the blue line, with aplastic anemia, and they looked at 408 adults with aplastic anemia, and these, children and adults received a bone marrow stem cell donation from Be the Match, from unrelated donors from Be the Match. So meaning that these were donors who are not brothers or sisters of these patients. And what you can see is that with the bone marrow transplant, along with the standard treatment, which is the immunosuppressive therapy, that in children, over 80% of children were alive at 60 months after the bone marrow transplant. And in adults, almost 70% of adults were alive after stem cell transplant. So what we're seeing is that with standard treatment, almost 8 out of 10 patients with aplastic anemia got better. So chance of recovery, though, depends on many different factors, including how bad your disease is, how you respond to the treatment, to the immunosuppressive therapy, and whether we're able to find a donor. Unfortunately, not all patients are able to find a donor on Be the Match, and that's the reason why we're constantly doing bone marrow transplant drives, trying to have more people register on Be the Match so that we can have a better chance of finding bone marrow donors in patients with bone marrow failure disorders. But overall, what we're seeing is that with aplastic anemia, depending on how bad your disease is, how well you respond to treatment, and if we're able to find a donor to do a bone marrow transplant, we are able to have a good prognosis for a good portion of patients, which is encouraging. So now that we've talked about aplastic anemia, we're going to move to talk about patients with PNH who also have aplastic anemia. So we remember before we talked about that fact that there is a group of patients who are positive for PNH cells, but also when we do a bone marrow biopsy, find out that they have aplastic anemia. So how is their prognosis different? Well, what we have seen is that patients with PNH positive aplastic anemia, they less frequently evolve or progress to MDS or AML compared to patients who have aplastic anemia and do not have PNH. We see that PNH positivity in aplastic anemia is a good predictor of response to immunosuppressive therapy. And there is a positive effect. So patients who have small PNH clones actually have better outcomes with stem cell transplant if they have PNH associated aplastic anemia. So on this graph, the dotted line are patients who have aplastic anemia and are PNH positive. And then the darker line are patients who are PNH negative aplastic anemia. And you can see that overall in this study that was published in 2021, patients who are PNH positive aplastic anemia actually do better than patients who are PNH negative aplastic anemia. So that is aplastic anemia. And then we discussed the prognosis of PNH-associated aplastic anemia. So let's talk about our third bone marrow failure disorder, which is myelodysplastic syndrome. So what is myelodysplastic syndrome? Myelodysplastic syndrome is a bone marrow stem cell cancer. It's a condition when the bone marrow does not produce enough healthy blood cells because of a cancer cell in the bone marrow. So myelodysplastic syndrome is characterized by these atypical, abnormal looking cells. The medical term for that is called dysplasia. We have impaired maturation of stem cells, meaning that the stem cells are not able to effectively grow and become mature working blood cells. And so you have ineffective ability to make the blood that you need. And so patients often present with low blood counts. And then there's an increased risk of progression to acute myeloid leukemia, which is a very aggressive blood cancer. So here's a picture of a bone marrow of a patient with MDS, and you can see all these abnormal looking cells. And you also see pictures of those cancer cells driving myelodysplastic syndrome, which is the blasts. the myeloblast that we know as doctors, we're always watching closely in patients with myelodysplastic syndrome. So myelodysplastic MDS, it's uncommon before the age of 50. We typically see the risk of MDS increases as we get older, but we definitely see patients diagnosed with MDS who are diagnosed at an age less than 50. Most commonly diagnosed in patients in their 70s is the median, but we definitely see patients younger as well as older. There's several different types of MDS, and again, it's the bone marrow that cannot produce the blood cells that you need because of these cancer cells in the bone marrow. And so here's another bone marrow biopsy, and you can see these large blasts that play such an important role in the symptoms of myelodysplastic syndrome. So as we discussed, there's many different types. And MDS is classified using the World Health Organization classification system, which was most recently updated in 2016. MDS, it's divided into many different types based off of how the cells look in the bone marrow under the microscope, as well as other factors such as the chromosome abnormalities. Remember the chromosome abnormalities that we looked at earlier, and the number of blasts, which is the cancer cell driving MDS in the bone marrow. And all of that information helps us decide what type of MDS, and that can play an important role because there's certain types of MDS, there's certain recommendations for treatment. So here's prognosis. So with myelodysplastic syndrome, we have followed patients for years, and we have done bone marrow biopsies on hundreds of thousands of MDS patients, and there's been many studies looking at myelodysplastic syndrome, and we know that MDS patients with certain abnormalities tend to do better than MDS patients with other abnormalities. And so we have developed this international prognostic scoring system, and it's calculated looking at your blood counts at the time that you're diagnosed with MDS, the number of those abnormal immature cells or blasts in the bone marrow at diagnosis, and then the chromosome abnormalities that we see on your bone marrow biopsies. You can see at the bottom that there are specific chromosome abnormalities that correlate with having a good response to treatment and living longer, and then there's certain abnormalities that are associated with more aggressive disease. So here's a focus on the chromosome abnormalities. So in purple are the good chromosome abnormalities. So patients with these abnormalities tend to live longer than patients who, let's say, have 3 or more abnormalities on their bone marrow biopsy, or they have specific abnormalities that are associated with very aggressive disease. And so all of that information, along with other factors. So your prognosis also depends, remember, on things that are not related to your MDS, such as how strong you are, how fit you are you someone who exercises every day, or are you, and then your age. So we know that patients who are older and have other medical problems may have more complications from the treatment of the MDS. So a group of international scientists and physicians came together to design the scoring system, and we use the scoring system along with the results from your bone marrow biopsy and your blood work to help us, put you in a group. So each person, so when we do a bone marrow biopsy, let's take an example. Let's say we do a bone marrow biopsy on a patient and your bone marrow blasts are less than 5%. So you get a score of 0 for bone marrow blasts. Let's say your chromosome abnormalities puts you in the good risk group, so you get another 0. And let's say your labs only do not show any abnormal counts, or maybe only one cell line is abnormal, so again you get a 0. So if you get 3 zeros, that puts you in the low risk group. And so the median survival based off of this scoring system is 5.7. So patients in the low risk MDS, an average patient in that low risk MDS lives about 5.7 years. Remember, this is an estimate, this is a guess. So there are patients who live longer than that. And so there are also patients who live shorter than that. So the scoring system for MDS It's just designed to help us predict how your MDS is likely to behave. And over time, we have added more information as we did more research so that we could try to make these scoring systems as effective and accurate as possible. But never forget that this is a estimate. This is not set in stone. As you know, these scoring systems have a lot of issues. They're not very accurate. And though we use it because that's the best that we have, but they're not very accurate, and they definitely can be wrong. So because of that, we continue to try to improve on these scoring systems. So here's a new iteration of the scoring system. We call it the revised IPSS. You can see now, instead of having 3 groups, so in the previous slide, you saw that we have low, intermediate 1, intermediate 2, high risk, and the chromosome abnormalities are good, intermediate, poor. Now with the revised, we have more knowledge about the chromosome abnormalities. And so now we have multiple groups. We have a very good chromosome abnormality group. We have a good chromosome abnormality group, an intermediate chromosome abnormality group, a poor and a very poor, that gives you different points. The bone marrow blasts have become more specific. So now instead of it just being less than 5%, now we have less than 2%. And then patients who are between 2 to 5%. And then patients who have bone marrow blasts between 5 to 10%, they get a score of 2. And then patients who have bone marrow blasts greater than 10%, they get a score of 3. So we check each variable where you are at diagnosis. We add up the points, and that puts you in a specific group that lets us estimate how, trying to predict, how long you're going to survive. And so this risk assessment plays a really important role, because now when we diagnose an MDS patient, we put all their information into this risk assessment model, and then we have a generalization. So let's say you fall into a lower risk disease. So our treatment goal for patients in this group is to decrease how often you need blood transfusions, improve symptoms, improve quality of life. But let's say you fall into the higher risk disease group. The treatment goal is we're trying to alter the history of disease, meaning we're trying to see if we can have you live longer than what the risk assessment, predicted. Prevent progression of AML, improve survival. And so some of the treatments that we do in patients who are in the higher risk disease group are hypomethylating agents such as azacitidine or Vidaza, or decitabine or Decagen. And in patients with higher risk disease, we also, consider bone marrow transplant or stem cell transplant. These are the same things. They're interchangeable: bone marrow transplant, stem cell transplant. So patients with higher risk disease, per the prognostic scoring system, the survival is shorter. So we need more intensive therapy to prolong a patient's survival. So overall, with these scoring system in MDS, based off of your score, we're able to put you in a less aggressive disease or a very aggressive disease group, and then we go after and then we make treatment decisions based off of your score. But again, I want to stress that this is a scoring system. It's an estimate, it's a guess, it's a prediction. It's oftentimes wrong. There have been patients that you may predict something, and then the patient actually lives longer than you predicted. So these are very imperfect, and more research needs to be done to actually improve on this risk assessment model. And so one of the things we're doing is we're looking at mutations in MDS. So greater than 90% of patients with MDS has at least one mutation abnormal gene. And so we know that there are specific mutations that are associated with more aggressive disease, like TP53 or ASXL1. And so we're starting to actually incorporate these mutations into these risk assessment models so that we can have a more accurate prediction or prognosis for MDS patients. So a lot of work still needs to be done. And again, bone marrow, like I said, bone marrow transplant is the only cure for MDS at this moment in time. So you can see that how important these prognostic scoring systems are to helping us decide not just your prognosis, but your treatment. And it actually is very complicated, but these prognosis and the tests that lead to prognosis can be very helpful. And again, like before, patients with myelodysplastic syndrome can also be diagnosed with PNH. And just like with aplastic anemia, patients with PNH-associated MDS actually do better. They progress, less frequently progress to AML. They have improved response to immunosuppressive therapy. They actually have better outcomes with stem cell transplant. And then, however, unlike with aplastic, however, patients with PNH-associated myelodysplastic syndrome are at increased risk for blood clots, which can be life-threatening. So remember that prognosis can be difficult. It's the hardest question to answer. And the reason is because ultimately we really don't know how long you're going to live as physicians, and we're oftentimes wrong. This is because each person is unique. We're all the blue duck. Each person's disease is unique and different, and the disease progression over time is unpredictable, and we have less information on rare diseases compared to more common cancers. And so I close by stating that that medicine is a team sport, and treatment decisions are made with you, your family, and your physician all working together. So bring someone with you to the doctor visits, and please ask questions. You know, you're going to make comparisons. You're going to decide the benefits and downsides of each treatment. And it's okay to say no. It's okay to say, you know, that this treatment is not working for me. And do lots of research so that you can be informed. Please, please, please ask questions and always take notes. I love it when patients bring out a notebook. Always ask for copies of your labs and important results like your bone marrow biopsies so that you can keep up with what's going on. And then know your medications, bring a list with you if it's hard to remember, and then always, always ask questions. So bone marrow failure diseases are complex and they require accurate diagnosis. Outcomes vary widely and treatment is tailored based off of these assessment tools. There's a variety of new agents that are being evaluated in research. And so, you know, I feel the prognosis is going to change. The prognosis, you know, from 10 years ago is completely different, as you saw with PNH. And it's going to continue to change as we get better and more effective treatments. So again, thank you so much for allowing me to spend time with you, and I am open to any questions.
Thank you, Dr. Niyongere. We do have several questions. I'll get to these right away. How usual is it to have a low to mid-risk MDS for years, and then suddenly it gets to the point of needing a bone marrow transplant?
That is actually very common. We do see patients who have low to mid-risk MDS for years. They do really, really well. Maybe they may need a little bit of, you know, treatments, maybe some injections to stimulate your body to make blood. There's some new drugs coming out now to help improve anemia as well as platelets. And we have patients who will just, you know, continue to do well, and then all of a sudden their counts are worse, and they're needing to start treatments with those higher intensive treatments. Remember, I discussed the Vidaza, which is the azacitidine, and then the decitabine or the Decagen. And at that point, we actually start discussing transplant. So that's very common. And that's the reason why we watch you very closely. You'll see that most of the time, you know, as you know, hematologists, we make our, you know, MDS patients come, you know, maybe every month, every 2 months, every 3 months, so that we can watch your counts, so that when you make that progression, we're ready to get you to start treatment and get you to transplant.
Thank you. Here's a question who asking for clarification. It seems as though you're saying that all bone marrow failure diseases are cancerous, but I didn't think PNH and aplastic anemia were considered to be cancer. Can you please clarify?
Yeah, so, you know, that is a great question. So, you know, technically, you're absolutely right that, you know, PNH, you have, you know, I would consider PNH as, you know, a possible, you know, I would say a bone marrow disorder, but it does have an abnormal cell or a clone due to a mutation. So, I mean, it could be, squeezed into a definition of being a cancer or malignancy, but definitely, I see where the thought process of calling PNH a bone marrow failure or disorder, because you have this abnormal cell due to a mutation that is causing your immune system to attack your blood cells. So it may be more described as an immune process. And so I definitely can see why you wouldn't call it technically a malignancy or a cancer. The same with aplastic anemia. We believe it's more like it's an autoimmune disorder. It's your immune system that's attacking your stem cells and resulting in having very low counts. And with immunosuppressive therapy, the counts will normalize. So absolutely, being a cancer doctor, I think of them as a malignancy because that's what I take care of. But you're right that aplastic anemia and PNH are actually more of an immune disorder where your immune system is not working effectively. It's attacking your blood cells, causing your counts to be low, which is different from myelodysplastic syndrome where you have a cancer cell that is driving the disease, as well as leukemia.
Thank you. Thank you for that answer. Next question. Can you talk about the importance of the size of the PNH clone as it relates to severity of disease and progression? This person was diagnosed with a small PNH clone of 2% and received conflicting medical opinion regarding its statistical significance.
Yes. So remember in that slide, I'm actually going to move it back really quickly. There is where we talked about there's a group of patients with PNH where their clone, I've just passed it, where their clone, is, let's say, less than 10%. They don't have any symptoms of PNH, but they technically, you have that abnormal PNH clone. And so in those patients, I will categorize them. I will say that you have PNH, but you don't have any symptoms, or you have subclinical PNH. So we identified that abnormal PNH cell. And so in those patients, we do not give any treatment. Instead, we watch, because there are some patients who have this PNH clone. That PNH clone never increases. It's just there, and it's just not causing any issues. And we just watch you. We just check your labs and make sure that PNH clone is not increasing. There's other patients where they'll have a PNH clone that's very low, and then over time, the PNH clone will increase, and then they will develop symptoms. And then for a good other portion of patients, we diagnose their PNH clone when it's very high, and they're having, all destruction of their blood cells, their counts are very low, and they're having blood clots. So the decision on, diagnosing PNH is just the presence of that abnormal PNH cell. And we will tell you, yes, we saw this PNH cell, it's this percentage. However, your blood counts are good, you're not having any symptoms, so we're just going to watch you closely. You're going to come see us, let's say every 2 months, every 3 months, or every 6 months, because you've done so well. But we're always going to monitor the size of the PNH clone. And then there's other patients where the PNH clone increases over the time, they start to have symptoms, and then we do treatment. So the decision on whether you have PNH is really, do we detect that abnormal cell or not? And so that will tell us that yes, you have that PNH clone. But the decision on treatment for PNH comes from your symptoms. So if you have a PNH clone, but you do not have any symptoms from PNH, your blood counts are good, you don't have any signs or symptoms of abnormal kidney or liver disease or kidney damage, liver damage, you don't have a history of blood clots, we're not seeing, all these destruction of your blood cells, we may not do any treatment, and instead we just watch you because you're not having any symptoms, you're not having any abnormal counts. So that is the significance of the size of the PNH clone. This is a generalization, but typically patients with higher PNH clones, they tend to have symptoms, but not always. Patients with lower PNH clones may not have as many symptoms, and we just can monitor them. So the importance of the PNH clone just tells us it's there. And then the symptoms, your blood counts, your lab results, that is what drives whether we need to do treatment or not. But just having that PNH clone doesn't mean we have to start treatment, because if you're not having any symptoms, if you feel great, if you have beautiful blood counts without any abnormalities, we wouldn't treat.
Thank you. And next question. You showed a survival chart for aplastic anemia that only went out 60 months. Is there any longer-term survival data for aplastic anemia patients, particularly those that had ATG treatment rather than bone marrow transplant?
Yes, that is such a great question. So we do have patients who are, cured of their aplastic anemia with the immunosuppressive therapy. So we have patients who will receive immunosuppressive therapy and they will live 10, 20, 30 years where their aplastic anemia never comes back. And so there is a group of patients who never require a bone marrow transplant. We estimate that there's over 60% of aplastic anemia patients who are, who are adults who will do well with just immunosuppressive therapy alone without a bone marrow transplant. Now, typically in children, if you have aplastic anemia and you have a donor, meaning you have a sibling who is a very good match, most of the time those patients, a number is, patients under the age of 40 will go to transplant. For adults who are older and do not have a good donor, we will do immunosuppressive therapy. And there is a large number of patients who they are cured with the, with the immunosuppressive therapy. And then we do have patients though with aplastic anemia where the aplastic anemia where they do not respond to the immunosuppressive therapy. That we estimate that there's about 30 to 40% of patients who don't respond to the immunosuppressive therapy. And at that point, we do other treatments, including looking at transplant options. And so there, I showed the that graph because of the fact that it had such a large number of patients. But there is definitely a group of patients who all they need is immunosuppressive therapy, and their aplastic anemia goes into remission and it never relapses.
Thank you. This is going to be my last question, but I do want to note for everyone, Dr. Niyongere was kind enough to provide her direct email address. So if we are not able to get to your question, please feel free to submit it to the email address that's currently on the screen. So this will be the last question we can address today. Would the stats for PNH with associated aplastic anemia be the same if the order was in reverse? This person had severe aplastic anemia, treated for it with ATG and cyclosporin, and considered in remission. The PNH diagnosis came years later, and they're aware that the aplastic anemia could return.
Yes. There's sometimes where, depending on when you were diagnosed with aplastic anemia, those studies are the same. So what we see is that patients with, aplastic anemia who have associated PNH, they tend to do better. And so, the data, that study did not differentiate between being diagnosed with PNH first and then being diagnosed with aplastic anemia, or being diagnosed with aplastic anemia and then later developing PNH. That study did not differentiate. It just included all the patients at once. And so that is such an interesting scenario, and I would love to be able to investigate more to see, could it be that PNH clone was very, very small and not detectable at the time that you were being treated for aplastic anemia? We don't know. Or you just, your aplastic anemia was in a remission and then you acquired the abnormality that led to your PNH. So, but yes, that study just included all patients. It didn't differentiate between whether you developed PNH first, or whether you were diagnosed with PNH first, or you were diagnosed with aplastic anemia first.
Thank you so much, Dr. Niyongere, for sharing your time and expertise with us today. If you would like to watch this session again at a later time, it will be available on the conference platform in the next hour by accessing the session and clicking on replay, or by navigating the on-demand tab in the platform hub. If we were not able to answer your question today, you can send it to us at any time in 3 ways. You can send an email to help@aamds.org. You can call our AAMDSIF helpline at 800-747-2820 extension 2, or you can submit a question on our Facebook page. Please be sure to visit the exhibit hall in the conference platform. The next session will start in just about 10 minutes. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and for making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to help you and your family, as we have for the past 37 years. This concludes the session.